Hey everybody, welcome back to the ECG channel. My name is Reed, and before we get started, don't forget that you can download the PDF of today's ECG video down from the description below, and so you can follow along and make your own notes. And while you're there, think about liking this video and subscribing to the channel if you want to see some more of these videos. So let's jump into this one. So the first thing I'm going to do is look at the forest, and the trees of the forest are my QRS complexes, and so maybe I'll pick V5 down here. I see I've got a narrow complex rhythm that seems to be quite regular, and it occurs throughout the entirety of the strip. The rate from QRS to QRS, if I find one that lands just about on the solid line, maybe here we've got 300, 150, 100, 75, 60, so somewhere between 60 and 75 beats per minute. You know, I'll say maybe 65 beats per minute, okay? I like to just take a glance to see what, the P waves are doing. And you can see in V5 here, we've kind of got this ugly baseline where it's just all over the place, and so you might think this is AFib, but I want you to remember that all of the time strips that are above you are recording the same exact electrical activity, and so sometimes you have an artifact on a certain lead, but in reality you actually have P waves. Okay, so notice how all of these are nice and flat, but this V5 electrode is a little bit bumpy, right? And so don't let that make you think that the atria is fibrillating, because in reality we've got P waves, and those P waves, if we evaluate the atrial activity, are upright in lead 1. And if you look in AVF, kind of hard to see, but you can see an upright P wave right there before that QRS. So that tells me that the P waves are going down and to the left, which is what we usually would expect coming from the SA node that's high and in the right atria. And so the next thing that's going to conduct our signal is the PR interval, which is our AV node. And so I measure my PR interval here at the beginning of my QRS to the beginning of the P wave. And if you look closely, that was probably a bad drawing. It's right on the lower limit of normal, right? That PR interval is about 120 milliseconds. And so that's a lower limit of normal, but I would say it's normal. And you can scan throughout to make sure that your PR intervals stay the same, and I see them as the same here. And I also want to look and make sure that there are no P waves that are somewhere in the middle of this rhythm that don't have QRS complexes. And so you might see some artifact. I wouldn't get too caught up in some of the artifact in this rhythm. I don't see any extra P waves, so my AV node is working properly. Next thing I'm going to look for in my evaluation is the AV node sending that signal down to the ventricles and creating our QRS complex. My QRSs, if you look, are upright in lead 1. They are upright in AVF. That tells me that my QRS axis is down and to the left, which is appropriate for the orientation of our ventricular conduction, so it's a normal axis. I've got good R wave progression. I've got my little septal R waves here in V1 and V2 that grow and become isoelectric in V3, where they transition to becoming R wave dominant, which is good in our, during the precordial progression. My QT interval, I like to eyeball that by finding, an R to R interval, maybe like this right here. And if you measure the midway point between the R to R, you should notice that the T wave should end at least by that point. And so I would say the QT interval in this patient is normal. And so now we're going to look for our ischemic changes. We've got pathological Q waves, which tell us about previous myocardial infarctions, or an aged indeterminate one, right? It can't tell you how long ago it was, but it can tell you that it happened. And also ST or T wave elevations or depressions that give you a bit of a picture on acute ischemia or infarctions. And so the first thing I think that stands out to all of us is that we scan through, we have V1 and V2 look normal, so septal we look good, V3, V4, anterior we look okay, V5 looks okay, and V6, you wonder, it's like, is that a little bit of ST elevation? Not a whole lot to make you think that we've got lateral infarction, especially with V5 being normal, but the inferior leads, which are leads 2, 3, AVF, I would say there is some ST elevation definitely in lead 3 and in lead AVF. And those T waves are awfully hyperacute. Look at the area under the curve of these T waves, a lot of area under the curve. And so we see that we have ST elevation in the inferior leads, which are leads 2, 3 in AVF. And so you want to see, well, is this, how much should I be worried? And so you look for reciprocal depression. And when you're looking at reciprocal depression for the inferior leads, you obviously are going to look something the most opposite, which is AVL in lead 1. And so lead 1, you can see just a hair of ST depression, right? You can see a little bit of ST depression, and you see a lot more in AVL, right? It makes sense that AVL has more depression than lead 1 because AVL is more oriented away from the inferior in comparison to lead 1. So that would make sense. And so things are starting to correlate anatomically here, that we're having an inferior STEMI, right, with predominantly lead 3 in AVF elevation, with less so lead 1, with reciprocal ST depression most prominent in AVL. And so if we put this all together, what do we think is going on? So we've got a sinus rhythm at a rate of 65 beats per minute. We have an inferior ST segment elevation, leads 2, 3 in AVF, with reciprocal depression that is most prominent in lead AVL. And so this actually was a patient who had a distal RCA infarct. So this was a distal RCA infarct, right? The right coronary artery supplies some of the right ventricle. It supplies the SA and AV nodes, and oftentimes will extend and give off the posterior descending artery as well.